Welcome to 105 session live from CMAAO. Uh, we are on 9th of April and 9:30 a.m. in the morning from India, Delhi. And I think all the representatives from various countries are joining in. We are about 19 countries a part of this association. And our aim is to bring the various topics. So today we are discussing on variant recombinations and way forward in COVID-19. This will be presented by uh, Dr. Shashank Joshi, who is an Indian endocrinologist, diabetologist, and a medical researcher. He is considered as one of the prominent practitioners in India. He's been also honored by Padma Shri, one of the highest civilian award by Government of India in the field of medicine. He's also a part of COVID-19 task force in the state of Maharashtra. It will be followed by a country update by all the representatives. So Dr. Shashank Joshi is traveling right now, but he would join soon. But we have a pre-recorded presentation by him, which we are playing right now. So you guys can see my screen.
Today, we are going
Yes,
to
we can
discuss
see.
COVID variants, particularly recombinants and the way forward. Because, across the world, there has been a concern that as the Omicron wave is receding and the BA1s and the BA2s are receding, there is a fear of recombinants. And let us take a bird's eye view of what's happening with COVID today and the way forward. We know the world is divided into two camps, the inevitability camp and the avoidance camp. The inevitability camp says when the Omicron wave came, it's mild, the lung-to-lung cell virulence is mild, the vaccine infection and T cell holds up very well, will protect versus severe disease. The booster shot is immaterial because it's going to last only for 3 months. We can't really worry about long COVID. We don't need really pills like antivirals, like the newer pills. And probably we can get over all this because we have hybrid immunity. But there is an avoidance camp. They feel that the disease is less severe and mild is not always mild. That's a big concern, even now hovering in Europe and US. Hamsters, mice, and cultures diseases are not equal to people. Human beings are human beings. And even today, we are losing people who are aged and immunocompromised or don't mount an immune response because we don't have an assured layer of defense. And extra doses of precaution doses are good. But despite of 4 doses, we are getting breakthrough infections. And we are getting a lot of debilitating long COVID across the world. And of course, the medical supplies for antivirals is limited. And therefore, we need to understand that the highly transmissible newer strains, particularly the BA1 and the BA2, are definitely around the corner. And they are more contagious, more transmissible. So clearly, when Omicron was born, somewhere in November of 2021, as the year ended, clearly it grew out from the alpha, beta, and gamma, which was totally replaced by the most dominant strain from the SARS-CoV-2, the Delta strain. And Delta's answer to the world to end Delta was probably Omicron, which originated from South Africa. So clearly the lineages, if you look at the origin, the transfer potential, clearly you can see the original strain, the alpha, beta, delta. You can see clearly with the arrival of Omicron, which is B1.1.529 from South Africa, Botswana, at the highest transmissibility, lower disease severity, and clearly the highest immune escape for previous infections. So this strain was mainly discovered between Botswana, South Africa, and Hong Kong between November 11 to November 23 with multiple spike proteins. And clearly it had that edge-in target failure. But initial strain, which was prevalent, was BA1, which was very fast overtaken by BA2, and BA2 did not have HG target failure. So clearly, if you summarize the Omicron, which is still the dominant strain now in the world, replacing Delta totally, it is clearly rapidly transmissible. It is a super mutant strain with more than 50 mutations. It has fully replaced Delta, and Delta was lethal, Delta was virulent, and Delta was a killer. Clearly, Omicron has immune escape. Breakthrough infections are common, but the severity and virulence of Omicron is less severe for sure. And whether it is BA1, BA2, or BA3, and BA2 is the one which is now creating havoc across the world. Clearly, you can see the differences between Delta and Omicron are very, very clear. That a number of mutations in Delta are sparse, Omicron are plenty. But the global fear is if these two strains combine, you might get a very deadly recombinant, and the media popularly called this as Delta Cron. And this Delta Cron created a huge fear in minds of people. Most of the reportages in the last 3 to 6 months were predominantly linked to probably contaminations, and they were called as recombinants. We know today COVID, as we talk today, if it is a Delta, we have an antibody. If it's Omicron, it's probably we have some antivirals. If patients are hospitalized, we have antivirals. The monoclonal antibodies which work now have moved away from the traditional casirivimab, indivimab, to sotorivimab, tiglivimab, and the newer ones which are coming quick and fast. COVID therapy all today is all about immune boosting through vaccines, neutralizing monoclonal antibodies of different types, immune modulators like steroids or the IL-6 blockers or the baricitinibs, and of course the antivirals, whether it is molnupiravir, whether it is nirmalatavir or ritonavir or remdesivir. But the focus clearly is no deaths, less number of severe and critical care disease, and mild to moderate disease. So what are recombinants? Recombinants are when two related viruses infect the same cell, that is during a co-infection, where the viral replication machinery can accidentally switch from one genome to another, resulting in a mixed genome. So when there is a mixed genome, as illustrated with co-infection, it is called as recombination. So these recombinants are something which is very common. SARS-CoV-2 recombinants has been doing it all the way through the pandemic. However, it is only easy to see when two parental viruses are distantly related. For example, alpha or prevariant. Therefore, the reason we are seeing a lot of recombinants until recently is we had a lot of genetically distinct viruses in the circulation, like Delta in circulation, BA1 in circulation, BA2 in circulation. And when there is a recombination or recombinants occurring between these lineages, like a Delta or a BA1 or a BA2, we can identify it even if the part of the switch genome is very, very small. And all this got highlighted because UK does a lot, and so does Europe, a lot of genomic sequencing. And therefore, you can see now that when the BA1 took off, at least in Europe and USA, there was a very high Delta wave already circulating. And you can illustrately see in the slide below that when there was already on top of Delta, when BA1 Omicron came, there was a huge opportunity of co-infection, recombination, and transmission going onwards. So clearly, what are the recombinant lineages? They fall into two categories. One is on the background of Delta, a BA1 which came on, and therefore, unfortunately, unhelpfully, the media labeled it as Delta Cron. And of course, then a classical recombination, which is now being described in UK, and some sporadic case reports which might occur across the world, including a questionable isolated case from Mumbai, which was reported this week. Clearly, it's a recombination of BA1 and BA2. So what are these recombinants of Omicron or the new recombinants? So let us study the first one of them. You can see on the orange and the red, the typical structural accessory from the ORF1 lab. You can see the green delta, the BA1 is magenta, and the pink, which is BA2. And you can see the XD strain has a little bit of green and little bit of BA1. So XD is a new name for the French Delta B1 lineage. And you can see here very clearly, this is the Delta green, and this is the B1 which has got recombinant. This was first sequenced and identified by the Pasteur Institute by Simon Lorliand and spotted by also Nguyen. It contains the spike protein of the BA1 and rest of the genome from Delta. And it currently comprises of several tens of sequences and possibly maybe more transmissible, but the virulence is unknown. The other popular recombinant lineage is the XE lineage, is a large UK BA1 BA2 combination. This was sequenced and verified by the UK Health and Security Agency and the Wellcome Sanger Institute, and it was first identified by Hitoshi Sakaguchi. It has spike and structural proteins from BA2, which you can see here, the BA2, and you can clearly see, but the 5' part of the genome is BA1. So this is the BA1, this is the BA2, and it comprises of several hundreds of sequences at present. XF is the UK Delta BA1 lineage, which means you can see you have a little bit of Delta and a lot of BA1. And again, Sakaguchi, Hitoshi identified it. The spike and structural proteins from BA1, but the 5' part of the genome is from Delta. It comprises of several tens of sequences. And then you have XF, which is UK Delta and the BA1. And clearly, this is something which we know. Now, remember these recombinant lineages. The United Kingdom has been uploading 10 times more sequencing than France. And therefore, the tens of sequences in France are roughly equivalent to hundreds of sequences from UK. How concerned we should be about these recombinants? Because remember, recombinants that contain spike and structural proteins from a single virus like XC or XF are fairly likely to act similarly to their parental virus. So there is no major fear or concern. If you have the XC variant like a BA1 and BA2, it is fundamentally going to behave predominantly like a BA2 only. So this is Finland, England, Sweden, and Israel, which did a lot of this phylogenetic recombinant trees. And you can see various things which are put out on the GSAID map. And these so-called XD, XC, XF, which are recombinants of Delta, BA1, and BA2, these recombinants have the structural and spike proteins from a single virus, as I told you, are likely to work very similarly. Also, it's very, very important to understand that you can get Delta BA1 recombinants, you can get the BA UK BA1 and 2 recombinants, and you can get DA Delta BA recombinants from France, from USA, from Queensland. All these recombinants, including smaller clusters, have not been assigned, should clearly be monitored for signs of growth, and attempts should be made to isolate and characterize wherever possible. And therefore, there is a full list available. For example, let us look at the Finland XJ genome and the BA1 and BA2 sequence from South Africa, and you can see some common mutations in the BA1 lineage and the comparison. So recombinants are here to stay. What can the recombinants do? They are more transmissible for sure, but they may not be more virulent at all. They may be less virulent. The other challenge which they can do is called immune escape. Whether it is the BA1, whether it is BA2 Omicron, or whether it is a recombinant, they will be immune escape. This is an old slide, but you can clearly see that SARS-CoV-2, whether it is natural immunity, whether it's vaccine-induced immunity, the virus, when it mutates, can have immune escape. That doesn't mean lives won't be saved. That doesn't mean severe disease will happen. It is less likely to kill. It is less likely to kill severe disease, but you do get immune escape in these phenomena. The final point, after looking at all the recombinants which we have studied, is fundamentally all about hybrid immunity. Fundamentally, for example, in a country like India, the large proportion of India had a Delta wave. And the Delta wave was predominantly there from first week of April to mid of May. And then we had between mid December to end of January, a large Omicron wave. So there has been a large exposure naturally to a lot of Indian populace on the Delta and the Omicron. At the same time, more than 185 or 190 crore Indians have been vaccinated. So therefore, when you look at natural immunity and when you look at the components and the tenets, whether it is the memory B cell, whether it is a CD4 cell, whether it is antibody or the CD8 cell, this is how the natural immunity tree grows as per Shane Crotty science paper. If you see the vaccine immunity, it may be a little more. But therefore, India, when you have 190 crore Indians vaccinated and a large exposure of Indians to a Delta wave or Omicron wave, what Indian population most likely is to have is an hybrid immunity. And therefore, the likelihood of another wave, like a fourth wave, disrupting our country is less likely in the next 3 to 6 months. So hybrid immunity is a way to go, and we will need that across the world. Clearly, when we talk on 9th of April, which is 2022, COVID still is predictably unpredictable. The only overarching feature in the way forward is to save lives, behave responsibly. If you are into a crowded space, closed environment, it may be preferable still to mask and definitely ensure that you get a vaccine shot on time. Both masking and vaccination is voluntary. But remember, what needs and where COVID still kills are those immunocompromised population, those populations who have comorbidities, those populations which have senior citizens at a large proportion, and therefore COVID can still kill in that vulnerable group. So I think we need to recognize that the threat of recombinants is real, but these recombinants are most likely to behave like their parental strain, and the Omicron strain related recombinants are not likely to pose a major threat in the near future.
Hey, so this was Dr. Shashank Joshi. I just got a message from him. He's just landed and he will join shortly. So you can have your questions ready and he would be available in next 5, 10, 7 minutes. Meanwhile, we can open the forum for the countries to give update. So can we start with South Africa?
Good morning, everyone. Last 24 hours in South Africa, we had new cases 1,377 and death is 9 total last 24 hours. Our active cases now 12,358 is came down. Recovery rate is also came to 97.0%. Positivity rate last whole weeks remain within 6.8. And our hospital admission around the country, public and private hospital, that is 2,138 patients were admitted. 161 patients were admitted in intensive care. 62 patients was on ventilator. Then our vaccination rate is now gone to 34 million. That's in short for South Africa. Thank you.
Would you like to add, Dr. Muzukwa and Dr. Angelica?
No, thank you so much. Good morning, colleagues. The only thing is that we are still, at the level where we think we are in between the waves, and there's scientists are warning us that we may get another wave somewhere early in May this year. So we're just monitoring the situation. Hopefully government is going to ramp up vaccination, which has plateaued at the moment. So hopefully by, if they continue encouraging people and on top of that, changing the strategies, the hope is that it's not going to hurt us so much. So I think that that's all from my side. Thank you.
If I can just add here, I think we've got nothing to be proud of regarding vaccination. Our vaccination drive is horrible after 14 months. And Dr. Joshi made a very interesting comment regarding the vaccines, the boosters, which I actually agree on. We have very good stats, especially in our surgery. And it's really clear for now that after 6 months, whether you had been vaccinated or previously had COVID or Delta in this case, after 6 months, we need to test. And because of these different types of lineages that we are seeing, we see a lot of clinical pictures that varies, and it's not a constant type of symptoms that the patient is coming in, leading to we have to be testing each and everyone coming in with an upper respiratory tract infection complaints, especially, as I've said, if it's 6 months past whatever they had last. And I think we're going to have a very, very difficult winter. And I'm really worried about the mask wearing component, especially in-house. Also, the WHO, for the first time, acknowledged that the virus is airborne. One of our leading scientists, unfortunately, he died during COVID, Prof. Stolz, within the first 2 months after COVID-19 started. He already said that it is airborne. Part of it is airborne, and no one believed him at that stage. And this is a huge concern. It brings us back to ventilation. That's one of the 4 pillars of non-pharmaceutical interventions. Thanks.
Thank you, Dr. Anjrika. Can I invite Dr. Maranda Pillai to please update?
Yeah, good morning.
Good morning, sir.
Of course, here in India, the number definitely are coming down. And yesterday we had 1,000 odd cases on the total, and the total number of patients with COVID is hardly 10,000 or so. Immunization, we are going very strong. 187 crores of vaccine has been given to the population. And of course, now we have extended the 3rd dose or booster dose to all persons above 18 years. Although to begin with, it was restricted to high-risk individuals. Now, all above 18 years are now eligible for vaccination. And that is where we stand as far as vaccination is concerned. All restrictions have been withdrawn, except, of course, COVID-appropriate behavior, that is mask wearing and hand washing. And there is nothing more to add because things are settling down. But we are a little concerned that in 2 states, even mask wearing is not compulsory. And to that extent, in these 2 states, we see that there is a marginal increase in the number of cases. And particularly the new variant XE, we don't know how far it is going to impact. As of now, no more information is available as to its potential for infectivity and seriousness. And at least 2 cases of XE has been identified in India, one in Maharashtra, Bombay, where still the confirmation has not taken place. But in Gujarat, there is a confirmed case of XE variant. Thank you.
Meanwhile, we also have Dr. Shashank Joshi. Yes, Dr. Shashank Joshi, we are waiting for you. Your presentation just got over. Thank you for joining in while you're traveling.
Yeah. I just landed in Jaipur. I had one announcement to make that Ministry of Health has confirmed that there is one XE case now in Gujarat and 2 XM cases, one in Mumbai and one in Gujarat. So the Mumbai case is still under investigation, whether it's XE or XM or XJ, like a Finnish variant. while the Gujarat case is confirmed as XE. This is just news as I have just got on, but definitely recombinants are on.
Okay, so I would now open the floor for the questions directly to Dr. Shashank Joshi. Dr. Angelica, you were asking something?
Yeah, just want to say thank you, Dr. Joshi. It was a very interesting presentation, and it actually confirms what we are seeing. And at the clinical level, I've just made the comment, and I agree fully with you. I am worried about the booster vaccines, and I've said it many times before. You know, you're only going to get people to boost up until a certain level, and then they're not going to boost, you know, to adhere to it further. And it is of a concern currently that it seems that the boosters are no much better than your own immunity if you had, you know, more than 6 months ago been infected. And either they need to up the boosters or the vaccines to be much more effective. But we're going to lose people. People are not going to vaccinate every 6 months just for in case they're going to get a new variant. I think we're going to see a lot of people not adhering to that. And I believe that Pfizer has now been approved for a 5th booster. So, and remember, you cannot boost yourself or vaccinate yourself out of a pandemic or an endemic situation going forward. So I think we're going to have a problem there. I'm not sure what your opinion on that is. Thanks.
Andrea, I completely agree with you that hybrid immunity is the best immunity. And the vaccine science is in still very early generation, and we need to improvise the vaccines. I have a lot of hope in the nasal vaccine. In India, we have one nasal vaccine undergoing research and clinical trials, and we really need to look at alternative routes of vaccine delivery and alternative platforms. The mRNA platform was a robust platform, very good for the spike protein, but it has limitations, and that is what the booster science has shown us. So I think the vaccine science is work in progress, and hybrid immunity and immunity, particularly innate, vaccine-induced, as well as naturally acquired natural immunity, is going to be the key as we live with COVID times to come. And waves will keep on coming and going. We only hope that even if the transmissibility goes up, the virulence should come down. And we have to protect our vulnerable groups. So I think that's the key. But I totally agree with you that we definitely need to do much more incremental innovation on our vaccine platforms, vaccine routes of delivery, and have better neutralization capabilities as new and new strains and recombinants will come.
Doctor, this case which has been detected in India is a patient from South Africa, right? Who traveled.
So that case was a costume designer from South Africa. She came to Mumbai. She tested negative when she landed. Then she had mild symptoms for 2 days, and she was absolutely asymptomatic, and she's gone back to South Africa. So, and her variant is not confirmed as XC. They feel it could be similar to the Finnish variant, though the nanopore laboratory in Mumbai did confirm that it was a XC. But I think now they are re-looking at the whole thing again. And but it is a recombinant for sure. The type of recombinant it appears to be a close relative of XC. That's all we can see. But mild disease, nothing to panic from that standpoint. But we need to be vigilant. So I think indoor air is from where the virus travels, and therefore in indoor closed environments we need to vaccinate for sure. I mean, do masking probably for some time may be needed.
Dr. Monica, your comments?
Sure, I'm just going to share my screen.
Yeah.
Can you see my slides?
It hasn't been shared till now.
Let me try again.
Yeah.
Okay. So I just want to talk about Dr. Kotze's comments and then talk also about Dr. Joshi's comments about spread and where we are. So in the US right now, this is the community transmission of all counties, and we've got BA1 and BA2. The last I heard from an infectious disease specialist last weekend was that we were 25% BA2 and 75% BA1 in the state of Wisconsin. So we haven't gotten XC in our state, but there's been a very strong kind of wish or will towards relaxation of social distancing measures, masking mandates, and we are seeing an increase in spread, but maybe not the virulence as Dr. Joshi was saying as well. And you can see what the transmission rates are right now in the past 7 days. This is just a snapshot from the New York Times in terms of what our vaccination rates are. And we are, as you can see, in April, we are really at a really low rate in terms of case count. I don't have updated information about the stool surveillance. But this is speaking to Dr. Kotze's question now about the fourth dose. So you're aware of the publication from Israel from a month ago, sorry, not a month ago, just a few days ago, about the fourth dose of the vaccine, and where there was a fourfold decrease in severity of disease at 6 weeks, and twofold decrease in the rate of infection. And you can see at times are on the x-axis, and you can see the severity of illness in the red dots with the bars, as well as the case rate or infection rate in the blue dots over here. And this week, we ended up having the CDC guidance on the fourth dose, that 12 years and older, immunocompromised, those who are 50 and older who are not severely compromised, who received the mRNA vaccine, can now receive their second booster dose. And then guidance for those who received the vector vaccine of Janssen, 18 to 49, who received their first dose, the booster dose, are also eligible for their fourth equivalent dose, or the third dose in this case, because it was a single dose series. And this is a philosophical question. When I approached my patients this week when the news came out about getting the second booster dose, we've already gone through spring break over here. Most people have already traveled and have already had their high-risk exposures. And they are looking at the second booster dose as something to do prior to their next anticipated travel over the summer. And they're feeling, those who are willing to get the second booster dose, that there will be an annual COVID-19 vaccine along with our seasonal influenza vaccine, which tends to start in September and goes until November here. And so if you end up getting a booster dose now or next month, that would be in June, then 4 months later, which is when we expect the vaccination immunity to wane, they would then get their next booster dose along with their annual influenza vaccine. Are people willing to do it? I think the number of people who are willing to get these recurrent booster doses are going to wane. However, as they get through this year, as Dr. Joshi was saying, even if it spreads more, you have increasing community spread, but the morbidity is less, maybe by the time we get to the end of the year and where the variants are going, maybe an annual booster will be enough. And it's just about tiding us to that time. Especially with the change in the approach towards masking and social distancing, and where we're seeing that there's been already, I think the estimate is that about 44 or 45% of the world has already been infected at this point, or at least prior to Omicron. That was a long answer, but I hope that brought some answers to the previous questions.
Thanks, Dr. Monica. Anyone has a question? Seems like COVID is ending, the questions are ending, which is a good part. See, the smiles are on the faces now. Dr. Joshi, you're mute.
No, I think we have to look at a life beyond COVID now. So I think it's better that we start moving into a post-COVID era and learn to live life with COVID. I think, every country has been battered and shattered. And I think now we have to get more responsible and resilient and live life. Whether it is United States or the most developed countries to the poorest countries, everybody's affected. COVID has spared no one. It has taught us a lot of lessons. I hope that we will have better future now.
Absolutely. And in fact, I think Dr. Pandit, Dr. Joshi, and Dr. Monica, we're all discussing that. I think now let's move our weekly meetings also from out of COVID, and let's see how we can include some important topics in the medical industry, which can actually help everyone else also in terms of lifestyle, in terms of what a specific field is apart from COVID. So anyone else over here? I can't see many names over here, but anyone else over here want to make a comment or want to give any update in this forum? Okay, that was a nice music, but
yeah. Saru, while we're waiting, I just want to say I think it's very important what you are saying, because this week on World Health Day, we had on CloudNet a very nice 1 hour discussion on lifestyle medicine in the current situation, and not only around COVID, but COVID plays a part, but what did we learn? And I think we should open this so that it's COVID related as well, but what else is now happening in the world? I agree with you on this Saturday morning.
Absolutely. I think I remember Dr. K.K. Agarwal used to say words to me saying, if you are not sick, then come to me. If you're already sick and you're in a case of emergency, then go to a hospital, because then you don't need us. Then you need an emergency, you need a hospital. How to make your lifestyle change, how to make yourself sure that you can live longer, then you come to me. You do not need to come to me when you're already at a stage when I can't do anything, or probably I can only say, live on medicines. So he was, I think, one of the very few people who do not want too many medicines, too many, tests and all that. He used to make sure that a treatment can be done in less than $2, or let's say 100 rupees for a person. And if you can change your lifestyle, if you can do preventive medicine, through a lifestyle modification, that was what he used to say. And I think Dr. Monica can add, because she was very closely working with Dr. KK during her time stay in India, if I'm not wrong. So we used to always go to him, when we were in a happy mood, when we were sick, when we were in a very, when we were at a stage where, we had a problem, then he used to say, okay, now you don't have to come to me. You better find a doctor for yourself who's a specialist then. But obviously he used to help. So Dr. Monica, you want to add something before we can end the session early, and I think you can sleep early.
Sure. So just speaking off of what Saurabh said, was that Dr. K.K. Agarwal had a very holistic approach to people and looked at their mental thought process and how they interacted with their environment and their health in their environment. And he understood the perspective of where the person was coming. And understanding your patient or the person in front of you holistically, I think, is going to be very important as we look at patients who have long COVID specifically. Not everybody had the same amount of disease. Not everybody's going to have the same amount of resources. And it will take a very holistic approach to bring all the morbidity that continues to exist because of prior COVID infections to bring them to the best and full recovery that if possible. But Dr. Agarwal's life lessons is probably the simplest way that I would put it, is that he all taught us how to live.
How to live. Absolutely. So thank you, everyone. If we do not have anyone else over here, because a lot of people have joined by the name of cell phone, and so I don't know who is there. So if anybody is there, wants to speak in this session, please do that. Otherwise, we will love to close this session early today, considering we have people around the world. So anyone else? Okay. So with this note, we would like to end this session. We will inform the next session, the topic in advance. Thank you so much for joining in. And thank you, Dr. Shashank Joshi, from joining in while he was traveling. Dr. Monica. Thank you, everyone else.